like, I mean, it's like, right? Yeah, I don't think that's the other. You know what I got really hard on? Yeah. It's, yeah, it's so cheap. Anyway, very excited about it. Good morning. Welcome to our final geriatric grand rounds of the school year. We're really glad to have Emily Stauffer here with us, a pharmacy resident. So today's topic is shown on the presentation. So excited to hear about CGMs and the geriatric population. Just in terms of other announcements, this is our final geriatrics grand rounds of this school year. We will kick off after Labor Day, so mark your calendars for September 5th. Jessica will send that calendar invite. If you're not getting the calendar invites, let us know. Journal Club is also now on summer break. And contact Jacob if you'd be interested in signing up to present at Journal Club for the next year. And expect to see signups coming your way soon, so please sign up. You will also receive the paper evaluation or the email link if you're on Zoom. And so without further ado, Emily is from Charlotte and attended the University of South Carolina for undergraduate and pharmacy school. She then completed her first year of pharmacy residency at the VA in Augusta, Georgia. She is currently completing her second year of postgraduate training here at our VA, specializing in geriatric pharmacy. So very interested in this topic today.
Thank you so much, Hillary, for the introduction. Excited to be here to talk to you guys today about this topic. I've spent a lot of time this year throughout my geriatric residency with different diabetic veterans, so excited to talk about what I've learned. So by the end of this presentation, I hope you all will be able to identify advantages and disadvantages to continuous glucose monitoring use in the older adult population, as well as understand available literature of CGM use in older adults. And then toward the end of my presentation, we'll analyze data collected surrounding the current patients in home-based primary care on CGMs and implement strategies to overcome barriers in current practice. Starting off with a little bit of background information. On the left of the screen, you'll see an example of a continuous glucose monitor, which is a small self-inserted sensor on the abdomen or back of the arm. These monitors work differently than our capillary blood glucose glucometers, which we traditionally picture when we think of how our diabetic patients monitor their blood glucose. These transmitters receive blood or glucose information from the interstitial fluid, which is definitely different than the blood glucose meters and often causes a lag in the sensor data, which I'll touch on this next screen. These monitors can take measurements every few minutes and can also reduce the need for finger sticks to detect those glucose levels. These monitors can look for hypo and hyperglycemia, as well as identify trends and have different alarms to alert of which direction the glucose may be fluctuating in a different patient depending on their activities and lifestyle. These monitors can also be paired with insulin pumps for our different diabetic patients as well. So here, I think this is a good graphic that I wanted to touch on the difference between the blood glucose and the sensor glucose. I think the train is a great analogy and really helps me grasp this concept. So when the train is on a flat track and there's little fluctuations in glucose levels, the blood glucose and the sensor glucose are very similar. However, when there's quicker changes to our blood glucose due to meals, insulin, or activity, the blood glucose is going to respond faster, and then that interstitial fluid is going to follow, which is displayed by the sensor glucose. So for example, when meals are had and our blood glucose rises due to the carbs, the blood glucose will rise quicker. And then on the sensor, we may see an arrow pointing up, but a lower level that will then catch up to what the blood glucose is reading. And then in contrast, when the glucose levels are decreasing due to insulin or activity, the blood glucose will then drop first and the sensor data will follow. And I think it is important to point out here, if a patient is having symptoms that don't match up with their interstitial fluid reading or that sensor glucose reading, always important to counsel on checking the capillary blood glucose glucometer to see exactly what their blood sugar is doing, as that will be the most accurate. So now that we've covered some basics of continuous glucose monitoring, let's go over how we get to where we are today. So since 1999, as you can see, we've moved mountains in the CGM field, and we've gotten lots of different new features and exciting things that I want to touch on today, and specifically relate to how we can use these as appropriately as possible in the older adult population. So in 1999, the FDA approved their first continuous glucose monitor. And then in 2004, alerts were then introduced to alert the patient of any low or high glucose levels, as well as trends. Then all the way up until 2014, the sensor life was then extended to 2 weeks or 14 days. So this is important as patients didn't have to change their sensor as often, which then can help with compliance and adherence to the monitoring system itself. In 2015, we see the first CGM that has compatibility with a cell phone. So patients are able to see all the readings just on their phone and not have to carry around like a phone and a reader or just different things that might also be more helpful for them. In 2018, we see the first closed loop system with an insulin pump and the monitoring system itself, so that the insulin pump and the readings from the CGM can work in partnership to deliver the appropriate amounts of insulin that the patient might need. Which then brings us to current day with our modern CGMs. Our modern day CGMs have improved size, features, as well as improved accuracy. I wanted to touch on the accuracy of some of the CGMs that we have today. Here specifically, I'll go through the 4 CGMs that we have available at the VA and the ones that I've had experience with throughout my different rotations in the clinics over there. As I alluded to with the changes in the capillary and interstitial fluid blood glucose, these CGMs can be less accurate in extreme changes or extreme levels of blood glucose, specifically when the blood glucose is less than 40 or over 400. Another data point that we see in a lot of the clinical trials for our CGMs getting approved is the MARD, or the mean absolute relative difference. The ideal percentage of a MARD that would show that a CGM is as accurate as possible to the capillary blood glucose would be 0%. So as you can see, we're definitely trending there, but we haven't gotten there yet due to the nature of how these systems work. But our Freestyle Libre 3 has a MARD of just under 8%, followed by our Dexcom G7, a little over 8%, then Freestyle Libre 2, and the Dexcom G6 with a MARD of 12.8%. Again, this is the percent difference of how the interstitial fluid is a little bit different, or it can be off from the capillary blood glucose. So they're not perfect systems, and they do have their flaws, so I think it's important to note that as well. So like I talked about, we have 4 different systems available at the VA, and I wanted to quickly go through some of the key differences in some of the 4 different systems that we offer for our veterans. Starting on the far left of the screen, we have the Freestyle Libre 2, which gives updates every 15 minutes and requires scanning on the sensor every 8 hours, which is in comparison to our Freestyle Libre 3, our newer version, which gives updates every minute and requires 1 scan needed when the new sensor is applied. Now comparing our Dexcom G6 and G7, our Dexcom G6 system is a separate sensor and transmitter, so there are like 2 pieces there that go into the application of the sensor itself, and requires a little bit more coordination for the sensor system to be applied, which I think is important to consider, especially in our older adult population. The Dexcom G6 also requires a 2-hour warm-up period and has placement suggested on the abdomen, whereas our Dexcom G7 is a much smaller system has an all-in-one sensor and transmitter package and only requires a 30-minute warm-up period with placement on the back of the upper arm recommended. So these are the 4 CGMs, like I said, available at the VA. And these are all examples of a personal CGM. So I want to take some time to compare personal CGMs and professional CGMs. This is something that I came across when I was looking into different data of older adults and continuous glucose monitoring. And I think it's important to just touch on this different type of CGM, as I typically only see personal CGMs in my experience. So those personal CGMs like the Freestyle Libre, Dexcom, those are real-time systems that give the glucose reading to the patient, which helps them understand the effect of diet and lifestyle on their blood sugar, as they can see the number changing in real life when they do something like eat a donut versus eat a salad, or go for a run versus like hanging out in the home, different things like that. These can then be used as a motivational tool as they see the numbers change in real time with their different lifestyle choices that they're making. These can also help guide insulin adjustments, specifically for our patients who might be on sliding scale insulin or have mealtime insulin that they're injecting as well. Alert to extreme glucose excursions. Like I presented at the beginning, these systems can alert to hypoglycemia. So that's exactly what these devices do. Our professional CGMs do have the option to be blinded to patients. So these could be applied in a clinic setting, with the provider being able to retrospectively review data to help guide the patient's changes to their regimen while in office for a visit or a telehealth visit, different things like that. These can also be cost effective, I found, and there might be opportunities for out-of-pocket costs to be minimalized when using these professional systems. These are also typically more user-friendly, as the patient doesn't have to do as much work to have like a reader or like an app on their phone to be able to see their readings. It's just kind of a different idea and a different way to think about CGMs and a different option. So how would we be able to get these systems for our patients? Now that I've reviewed some of the ways that these work and what options and opportunities that they have to help our patients. So here I have the Medicare coverage, which was updated in 2023 to give us kind of a flow chart on who would be eligible for these systems. I'm not going to go into super depth with all of the different bubbles and lead you through this whole chart, but at a bird's eye view here, the patient needs to have diabetes, treated with insulin, and if they're not treated with insulin, they should have a history of problematic hypoglycemia. And then they spell out specifically the specific blood glucose level and frequency of the hypoglycemia, which would then make them eligible for the system. They also require that a patient had been seen for diabetes management in the past 6 months, which would then make them eligible through Medicare Part B to be able to get one of these systems. So I think it's interesting to compare the Medicare coverage to our VA criteria for use. We can see some of the similarities, and I'll also point out some of the differences here as well. So this is not an all-inclusive list for our whole criteria for use. It's a couple pages and a little bit involved, but I also don't get into the exclusion criteria, but I'll save that for another day. So just to kind of glance over this as well, our inclusion criteria at the VA is that the veteran has a diagnosis of diabetes, has someone that can help them, or they can successfully utilize the CGM, as well as be able to follow recommendations from providers so that we're making sure that a patient is safely using this device when we do supply them with it. And the patient also must agree to ongoing appointments every 6 months so that we can monitor this and use it as safely as possible. Now, I think it's interesting, this additional inclusion criteria box that I have on the bottom of the screen, which really gives us some different leeway in comparison to the Medicare coverage over at the VA. to be able to explain different circumstances or different situations that our veterans may be in. So the first bullet here, patient requires intensive insulin and at least one of the following. This is pretty similar to that Medicare coverage that I covered on the previous slide, with history of hypoglycemia, inability to meet glycemic control. Again, touching on how important history of hypoglycemia could be to make a person a great candidate for one of these symptoms. And then preconception planning or pregnancy, which I don't see a lot at the VA with our veterans, but nonetheless, it's on there. And then insulin pump therapy could also count as one of those additional inclusion criteria, in addition to someone meeting all of those top boxes. And then I think our last two bullet points is where I really think it's interesting that the VA would be able to offer these systems for veterans who have kind of unique situations. So really pointing out that there is an other situation box at the bottom that you can provide justification for maybe a unique circumstance for a veteran who might not have a caregiver, who is able to take their capillary blood glucose every so often. They might have a nurse come in who might be able to scan the CGM. For example, if this was like a paralyzed veteran or an SCI veteran, all those different unique situations that we could use as justification to get our veteran this system. So once we have obtained the system, what do our guidelines say for recommendations for these types of systems? The 2024 American Diabetes Association has recommendations specifically for continuous glucose monitors. Again, these aren't specific to the older adult population, but I do think they're important to include. They first state that CGM should be offered for diabetes management in adults with diabetes on multiple daily injections, and they recommend that this person can use the device safely, either by themselves or with a caregiver. They go on to state that the choice of device should be made based on individual circumstances, preference, and needs. So with that being said, this is where they do jump into kind of differentiating how we can use these CGMs in our typical population in comparison to our older adult population. So here I have the different clinical targets for time and range for our continuous glucose monitoring systems. On the left in the blue box, you can see what the ADA recommends for type 1 and type 2 diabetics. Here, I want to point out that the target range is somewhere around over 70%. And then comparing that to our older and high risk type 1 and type 2 diabetic cohort here in the green box, you can see the time in range that they recommend is a lot lower, so somewhere around 50%. So a lot less stringent goals here. And then that's our target range, but then they're also a lot more lax for the higher blood glucose levels, as we would much rather prefer our older patients to maybe fluctuate a little bit higher than risk hypoglycemia, which, as we all know, can definitely cause bad effects for our older patients, like falls, coma, the very worst, etc. So you can see those yellow and orange bars are much, much bigger in the older and high risk box, that green box. And then for the red sliver on the bottom there for hypoglycemia, they're a lot more strict for our older and high risk diabetic patients, as we definitely want to minimize that for the reasons that I mentioned. Here is just an example of a blood glucose report, and I wanted to point out some of the different features and how they relate to our older adult population and where I like to look and grab information from, as these devices can not only be overwhelming with information for the patient, I think sometimes they can also be overwhelming for the provider to see the amount of information that these reports can give us, as there's often pages and pages of information and different graphs that we can look at. So here I like to point out the continuous glucose monitor report. And on the left of the screen, where I just pointed the arrow, our GMI, or the glucose management indicator there. This is a percent that we can use to extrapolate what an A1C might look like. Now, these different reports can have different day ranges that you select. So you can really tailor these around your patient and your different clinic visits that you might have with them. So the GMI isn't necessarily over 3 months like our typical A1C is, but you can adjust the dates and see possibly what it might be looking like with the patient's current glucose control. I think it's also important to point out that these devices give us glucose variability percentages. This is important because our typical capillary blood glucose log that a patient might bring into clinic really only give us snapshots of what their glucose look like throughout the day. So this glucose variability percentage really shows us how someone's blood glucose may be fluctuating throughout the day and show us more than just a snapshot in time. Here on the right of the screen, I want to kind of wrap up what the ADA showed us with the time and ranges and where we can find that on the report. So it's typically on the right hand of the screen whenever I pull up the LibreView reports on my laptop. So there I can look and make sure I see exactly where our veteran or patient is lying with our different goals that we choose for them. And as a geriatric resident, I usually am looking at those more lax requirements for the time and ranges and really making sure and stressing that the patient isn't having much time being in the hypoglycemic range. Then at the bottom, this is just an example of one of the many graphs that the LibreView provider report will be able to provide for you. This one is just an example where it pointed out where a patient was going higher in the afternoon and evening. So that could help us tailor this specific patient's insulin regimen. Okay, so now that I've covered a little bit of the basics, kind of how I have used the CGM reports and data, I wanted to compile a list of advantages and disadvantages, and then I'll use this list to make a list of ideal and not ideal candidates on the next slide. So I really wanted to piece out and break down what I thought about all the different things that I had seen and read throughout this year about continuous glucose monitoring. So in advantages, 24/7 monitoring. These systems show us glucose levels throughout the entire day. Again, like I mentioned, not just that morning reading before breakfast, not just that before dinner reading. We have 24/7 monitoring, and we could see how this specific patient's blood glucose is fluctuating throughout the day, which then leads me to trend analysis. We're all able to see exactly when a patient may be going high or low, which is very important, again, in the older adult population to be able to minimize hypoglycemia when possible. So important to be able to see those trends so that we can counsel on diet, snacking, those types of things. Real-time notifications. I think it's important for older adults, again, to know when they might be hypoglycemic or even trending toward hypoglycemic, as that can definitely be detrimental to their health. So I think that's really an advantage of these systems. Excuse me. Motivate patients to achieve goals. Here, I think that these systems can really motivate people when they do see those numbers and get those notifications that they want to meet their goals after having conversations with their healthcare providers about what their goals are. I think that's really important, and I've seen that a couple times too, where patients have used these CGMs and then felt really involved in their healthcare, and they really feel like they're a part of the puzzle to get everything figured out to meet their A1C goals, etc. Reduce need for finger checks. I think we've all probably come in contact with a patient who hates this part of diabetes, using the finger checks and having those uncomfortable finger sticks. So this could definitely be an advantage of these systems for the appropriate candidate. Also, a CGM can overcome the limitations of an A1C. A1C does only show us 3 months, and there can be different reasons an A1C is falsely elevated or lowered. What first comes to mind is anemia, so I think it's important to remember that the CGM looks at different data other than the blood, like an A1C. Next, moving on to disadvantages. A disadvantage of a CGM, not only is the data overwhelming to healthcare possibly, a healthcare provider possibly, but it could also be overwhelming to the patient. They could be seeing all this information and getting really overwhelmed and even stressed maybe that their glucose is being too high at different times. They might start like self-restricting what foods they're eating, which could then contribute to a worse quality of life and lots of different things as patients might fall down that rabbit hole. Alarm fatigue. I know I get a lot of notifications on my phone from different apps that I turn off because they're annoying, but I can only imagine what a patient with CGM might feel like if they're getting all sorts of alarms all the time. And then they might get that really important notification that they're going super low and having an extreme low blood glucose level and ignore it due to alarm fatigue. So I think that's an important thing to point out there as well. Uncomfortable irritation. These sensors do have adhesive on them, which can cause some uncomfortableness for the patient wherever they decide to apply their sensor. But nonetheless, I have never personally worn one of these, but I can only imagine that there might be a piece to irritation that is in play there. And I've definitely worked with veterans who have mentioned that to me as well. Only as helpful as a patient allows. I think this is sometimes, that patient in clinic that gets this information, but they don't really want to act on it. And then I'll touch on that on my next slide with who I think might not be an ideal candidate for a continuous glucose monitor, as these are important resources that we're able to provide our patients with. But I think that we need to use them wisely for many different reasons, cost to the healthcare system being one of them. Cost to the patient, however, might also be a disadvantage if they do not qualify for these types of systems through Medicare. A disadvantage, these systems can be frustrating for some to learn. This makes me think of especially the older adult who may have some cognitive impairment and some challenges learning new things. I think these types of systems could cause some frustration and stress with all of the different bells and whistles and new things that you have to learn when applying one of these sensors. Given all those advantages and disadvantages, I compiled this list of who I believe would be an ideal and not ideal candidate, and study up because we're going to play a game on the next slide. So, ideal candidates, Wi-Fi, internet, email. I think this is really important as the patient will then be able to upload their data in real time, which then makes these healthcare appointments really productive without having to chase around a caregiver or someone to go out to the house or a nurse to upload these types of information, which then leads me to my next point, tech savvy. Not only should it be important for a patient to have Wi-Fi, internet, email to be able to upload all this data, but tech savvy enough to download an application, tech savvy enough to navigate through the different interfaces on the app, I think is really important for someone to be able to really use these systems to the best of their abilities. An ideal candidate, in my opinion, would be someone who has an intensive insulin regimen, like our type 1 patients, again, to monitor for low blood sugar, since they are on insulin, which does have the ability to cause those numbers to drop. Hypoglycemia history or unawareness. I think these systems would be really ideal for someone who has a history of hypoglycemia, so we can really pinpoint in when the time and space that someone is experiencing those low blood sugars, so we can get to the root of the problem. And then unawareness, I think it's really scary when we have a patient who doesn't know that they're going low and they're not able to detect themselves when their glucose levels are dropping. So if a system could detect that for them, I think that would be a really great addition to their care. Dexterity to place sensor or have help. Again, I've never placed one of these on myself, but I have educated veterans on how to place these sensors. And there's definitely a level of dexterity to place these sensors with both arms, being able to have the strength to apply the sensor with one arm and then raising your other arm, I think is something to keep in mind, especially with our older adults who may not be able to do some of those different things. Moving on to not ideal candidates. So unwillingness to check capillary blood glucose. I think if a patient is just unwilling to, do those annoying finger sticks, this is something that needs to have a conversation happen between the provider and the patient, as if someone's just unwilling to check their blood glucose. The system could be used for someone else who might have a more compelling indication for these systems, again, so that we can be using these resources as wisely as possible. Unwilling or unable to use data to make decisions. If a patient is getting information from their glucose monitor and they're not reacting appropriately, I don't think that this patient would be a great idea to have a CGM for, as they're not able to react appropriately, and that CGM could be used for a patient who could really meet their targets and feel really motivated to reach those targets. Burden of device outweighs benefits. Again, with the frustration that this may cause for some who might have trouble learning new things, sometimes the burden of the device might outweigh its benefits. Just making sure that the patient is safe, but again, not wanting to cause extra stress, specifically as the patient may be getting older. Inability to upload data for providers to see real time. I have definitely experienced this in clinic where patients, again, either don't have Wi-Fi, internet, or email to be able to upload that data in real time. So I get all excited already for the appointment with all of my data and all of my research, and then just to walk in and have no blood glucose readings. I think it's really frustrating for the patient and the provider, as there's not able to be a productive visit to be able to really assess fully what their regimen has been doing to their blood glucose levels. Well-controlled diabetes, as well as maybe a patient being on oral medications that don't have the risk of hypoglycemia. Those patients might not be ideal candidates, as they might already be meeting their goals and not need to see what their glucose is doing 24/7, 65 or 365 days a year. Dexterity issues, the patient isn't able to place the sensor or have someone to help them place the sensor. That would also only not qualify them to be able to have a CGM at the VA, but they wouldn't be able to place the sensor and we wouldn't be able to use it. So with that being said, who would be the better candidate? Now that I've gone through some advantages and disadvantages, I have a question for you all. Who would be the better candidate? I have Mr. A, and he lives in Silverthorne, Colorado, with his wife, who is his caregiver. What matters most to Mr. A is staying at home with his wife. His current diabetes regimen consists of metformin. He has no history of lows and has a well-controlled A1C. The wife and veteran do not have cell phones, but they do have a landline home phone. I also have Mrs. B here. She lives in Boulder, Colorado, with her daughter, who is her caregiver. What matters most to her is not losing a leg due to a diabetic foot infection. Her current diabetes regimen consists of greater than 3 insulin injections daily. She has a history of lows and currently has an uncontrolled A1C, and the daughter and the veteran both have an iPhone 13. So does anyone have any thoughts on who might be the better candidate? Mrs. B. Yeah, so I was we got a Mrs. B from the chat too. So I was thinking that Mrs. B would be a pretty good candidate for a CGM. She lives in Boulder with her daughter, who is her caregiver. Sounds like her and the daughter both might be kind of tech savvy if they both have an iPhone 13. After, a clinic visit with them, you might be able to further assess this and make sure that they would be a great candidate. So the daughter might be able to help navigate all the different things, the different tech things that come with CGMs. What matters most to Mrs. B is not losing a leg due to diabetic foot infection. So I think a CGM could help Mrs. B maybe get more controlled, since looks like she does have an uncontrolled A1C and history of lows, so we could monitor for the lows and then maybe get her A1C under control, which could then help her risk of developing a diabetic foot infection. And the amount of insulin injections that she's on throughout the day would also help qualify her for one of these systems. All right. So when I was putting together this presentation, I also wanted to dive into the literature and see what's out there about older adults and continuous glucose monitoring use. So I found some interesting information that I wanted to share with you all today. First, starting off with how prevalent these systems are. This was a prospective study which included 6,800 patients with diabetes and insulin therapy, a mix of type 2 and type 1 diabetes, but the patients were 60 years or older. This data was from 129 treatment centers from the Diabetes Prospective Follow-up Registry from March 2023 was when they grabbed this data. They found that some predictors for sensor use was those patients that were on the younger end of age range greater than 60, and also those patients who had a continuous subcutaneous insulin infusion, so an insulin pump. These authors predicted that there will be a further increase in CGM as our years go on. So I put together this chart on the right to explain what they talk about in their article. Through 2019 to 2021, there was an increase in the percentage of population 60 years or older that used CGMs. So I also agree with their prediction that CGM use will only increase as we start to see more of these come on the market with more different advanced features and accuracy improves. Now that we know that these are getting more common, what are the safety features and data that we have for older adults with these systems? So this one specifically, the study they looked at specifically looked at low blood sugars and CGM use. Again, as we all know, important to limit low blood sugar in our older population specifically. This study looked at those older than 65 with a history of type 2 diabetes and those who had an A1C between 7 and 9%. So this graphic is a little blurry, but I really wanted to visualize here for you all how this study was designed, and this is how I grasped it well. So upon eligibility, after patients were screened, patients wore a first set of CGM for 14 days, and then data was collected and put into its own bank of information. And then next, the same patients wore different CGMs for 6 weeks, and they were continued to be changed out. And so data was then grabbed to be able to compare kind of the changes that patients had when they had been wearing CGMs for longer and see if there was any difference in low blood sugar. So here on the left of the screen, that first bar, this is the baseline group. So this is all those people in that study who had worn that first sensor for the first period of the 2 weeks. So that group was found to have 4% in the time below range or hypoglycemia. And then that second bar there shows that about 2% of those same patients who had worn that CGM for longer after 6 weeks had less hypoglycemia, so 2% compared to 4% when they had just worn the sensor for one cycle, 2 weeks. So here, the authors concluded that older patients wearing those CGMs found that they had less hypoglycemia after utilizing the system for longer. Another study that looked into low blood sugar hypoglycemia in our older adults was done by Pratley and colleagues. The objective of this study was to determine whether CGM is effective in reducing hypoglycemia versus standard blood glucose monitoring in older adults with type 1 diabetes. This was a randomized clinical trial conducted at 22 endocrinology practices in the US among 203 adults that were at least 60 years old. They randomly assigned patients to either a CGM or standard blood glucose monitoring, and their primary outcome was CGM measured percentage of time that the sensor glucose values were less than 70 during 6 months of follow-up. Here, importantly, I wanted to point out the severe hypoglycemia data that they received after their study time. So in the CGM group, they found one patient who had severe hypoglycemia in the older adults, and then standard blood glucose monitoring, there were about 10 patients who had experienced severe hypoglycemia. Then at the bottom of this chart, their main outcome. So the adjusted treatment difference of time that was spent being low or having a low blood sugar, they found that although it was small, it was statistically significant that CGM had reduced time being in the low range. They also found that there was a statistically significant difference in hemoglobin A1C between the CGM and standard blood glucose monitoring group. Again, small 0.3% difference in A1C there. To kind of wrap up the data that I looked at, there are two more trials, the Mobile 2022 and Diamond 2017 trials that I wanted to look at. So the objective of both of these was to evaluate efficacy of CGM in adults with type 1 and type 2 diabetes on insulin versus self-monitoring their blood glucose. Mobile 2022 looked at those 65 years or older, and this was a multi-center randomized open label parallel group trial in the United States. Their selected outcome that they looked at was time and range difference. And they found a statistically significant greater impact in those that had the CGM, found that they were in range more than those who had just been self-monitoring their blood glucose. Diamond 2017 looked at those 60 years or older. It was a multi-center randomized clinical trial in the United States and Canada. The selected outcome of this trial was hemoglobin A1C reduction from baseline to 24 weeks. And they found a statistically significant decrease in A1C of about 0.4%. So it's kind of similar to that first one the one that I covered before this, which was about a 0.3% reduction in A1C. All right. So key points of all that data that I just covered: prevalence of diabetes increases with age, and the population is generally living longer. So we can only expect that there'll be more older patients with diabetes on CGM, as the use of those devices has expanded rapidly in the last decade and is predicted to continue to rapidly increase. Data shows significant benefit in different glycemic metrics, which include hemoglobin A1C improvements, less hypoglycemia, and improved quality of life. However, subpopulations such as older adults and type 2 diabetes do exist where data is limited. I covered most of the information that I was able to find on PubMed about this group, so I think there's definitely some space there for some more developments. So now that we know continuous glucose monitoring is growing and going to be quite prevalent, I want to talk about some of the data that I collected throughout my time in home-based primary care. Home-based primary care is a program at the VA where veterans are able to receive care from their home. And we definitely have a good percentage of those veterans in our home-based primary care program who are diabetic. So we started to see more patients coming into the program, being admitted to the program that had CGMs. So kind of the who, what, when, why of what I was looking at. So I collaborated with our VISN PBM data manager, which is a person who is assigned to a certain subset of different VAs to gather data for different projects, much like one of this small project that I did here. And I collaborated with the data manager to pull home-based primary care admission notes and sensor dispensed within 30 days. I asked the data manager to pull the Guardian sensor, as well as both the Freestyle Libre and Dexcom sensors that we had available at the time. I also asked for the home-based primary care pharmacy note and sensor within the last 6 months. So I was able to make sure that I wasn't missing anyone and no one was falling through the cracks who might be admitted to the home-based primary care program and be on a CGM. So when did I pull this data? It was the beginning of this year in January. And why did I pull all this data? So I wanted to look at all of this information to be able to identify veterans who may have been lost to follow-up that are on CGM, which, if you can recall from the VA criteria for use, they require follow-up every 6 months or so to be able to accurately assess how the CGM is doing and how the patient is doing with the monitoring system. So the data that was collected per our data colleague, I was able to receive veteran name, last four, so that I could go into the chart and grab some more information. I was able to get the sensor name, the sensor release date, and the primary care provider. Then after I got all of that information, I was able to then look up the veteran and really dig into what I wanted to find out, which was how were these veterans being followed, and were they being followed appropriately, and were there any gaps of care? So I went in to look for who was managing the continuous glucose monitor and found when their last appointment was, when the CGM was started, and if they had a return to clinic scheduled. My results, there were 17 unique veterans that were identified after I removed 2 of the duplicates, and there was 1 unique veteran who had 2 different sensors. So all in all, I had about 17 veterans to look through, and then throughout the specified time period that I was looking for, there were 3 veterans who were discharged from the home-based primary care program for whatever reason. And then 1 veteran had a CGM discontinued because that specific veteran was meeting their goals and didn't need the system anymore, which then left me with 13 total veterans that I could really hone in on and see if there were any gaps of care. Of those 13 veterans, I identified 4 that had possibilities for gaps in care. For one of our veterans, endocrinology had deferred management to home-based primary care, and it was unclear if the primary care provider was aware that they were now monitoring that CGM. On 2 occasions, we had 2 veterans with no endocrinology follow-up in the last 6 months. And then we had 1 veteran with an active sensor ordered, but they had not been able to be placed for a certified diabetes educator appointment. So they were kind of lost in space there as well. So my plan and how I reacted to this information, I notified the home-based primary care pharmacist that was on the team of each veteran in their respective groups, or referred to endo for follow-up to get them scheduled for their next follow-up so that they could continue to meet our inclusion criteria and keep receiving their monitor. An additional finding throughout my research was that I found that the home-based primary care clinical pharmacist practitioners followed up with their veterans closer than anyone else who had been following for continuous glucose monitoring and diabetes management. As part of that project, I reached out to clinical pharmacist practitioners throughout the country to see what barriers they had identified in their practice, to see if they were experiencing some of the things that we had been experiencing throughout my time there as well. So here are some of the big main points that I identified after going through all of the emails that I sent out through that big email chain. A big challenge was technology and making sure veterans had compatible devices, making sure that their phones were up to date, like the iOS, Apple was up to date, all these little things that you might not think about when you think, oh, this patient might be a great candidate. But there really are a lot of things that need to come to mind when you identify a patient who might be a good candidate to make sure that they're able to use the system to the best of its ability. Education, training patients and training staff. currently. There has been some barriers identified that these aren't in place or there's not enough staffing to be able to conduct these sorts of trainings for staff and the veterans. So I think that once these are in place, that'll definitely help smooth through the process of getting someone started on one of these systems. Sensor issues, dexterity for application, or falling off a patient unintentionally removing. I actually did have a patient with cognitive impairment who was unable to remember why the sensor was applied. So they would continue to remove the sensor. So I think that's another thing to kind of think about a nuance with our older adult population. Now to wrap everything up, I know I went through a lot with the data. And then what I kind of saw in my practice and covering some of the background informations. But I do think that CGMs are valuable tools for patients and providers. And I think that they can provide diabetes management improvements and improvements in outcomes like I covered in some of the studies that we looked at. I do think, however, that CGM use should be tailored to the individual patient and that patients should be carefully selected, especially in the older adult population with all the different challenges that come along as we grow older. Future research, I do believe, is needed to further investigate the effects of these systems in older adults with diabetes so that we can really hone in and find who we think would be the most ideal candidate for these systems. And with that, here are my references, and I can take any questions.
And then Emily's also able to monitor the Zoom, 33 people on Zoom for each out in the room.
Hi, thanks so much for the great talk.
Hi.
I was trying to find some of the inclusion criteria. I think it was the mobile study. And there's like 3 levels of supplements you have to go through to find that for that trial. But it doesn't seem that they actually excluded people with dementia or like lack of access to technology or any sort of like, all the criteria that we sort of view as the most optimal patient for these. And you obviously mentioned that in your conclusion slide that how do we really know who the optimal patient is? But I do think it's interesting that like that mobile trial shows that their time at the severe lows is less, even though they didn't technically exclude patients with dementia or patients with lacks of access to technology. So I'm curious if it's possible that we're maybe even a little conservative with the CGMs because of our concerns. And I'm hopeful that more data will be there to demonstrate a value or not. But I'm just curious, I think on an individual level, we can all think of a patient that a CGM didn't go well for. But in your experience, do you think that we're too conservative sometimes with when we decide to do it or not for patients?
Yeah, I think that's a really good point about the mobile study and including those, maybe with or without cognitive impairment. But I think where my mind first goes with that is I wonder if they had like a caregiver or what their support system looked like at home, because I have definitely seen some success stories with these systems of veterans that have, a really great support system, a great caregiver, home health nurses that can assist effectively with these systems. But then again, I feel like you said, there's always that in the back of your mind of, oh, I've seen this film before and I know exactly what happens. So I think that I would be curious to see the people in that mobile trial of what kind of support they had. And I think that's another thing too, that I should incorporate into like those CGM visits where you're trying to establish if that person would be a good candidate, kind of figuring out what their support system is and who they have to help them along their like diabetes journey, if you will. I saw something in the chat.
The question.
Oh, please,
chat.
Hillary,
So,
thank you.
Did you come across any data or clinical experiences in which the patient having access to CGM data caused them to inappropriately use insulin?
Yes. I think, again, that's kind of one of those things that makes you maybe not cringe, but it makes you scared for when someone gets all this data that they may have not been able to receive previously, and then, they think that they can be reactive in a situation where, as we know, working with insulin, it's not really the best to reactively help a situation. And I've definitely come into contact with experiences where I found veterans like insulin stacking and things like that, when they've tried to react to different numbers that they see on a CGM, specifically when they see numbers go super high after eating ice cream or something, which they wouldn't normally see those values if they didn't have a continuous glucose monitor. So I do think that might be one of the things that causes stress or frustration for patients that might have those devices.
This is very timely. Thank you. I wanted to give a heads up for something we'll hear about at a future clinic staff meeting and seniors clinic, as some of our endocrine colleagues are going to be recruiting folks with new diabetes diagnoses to study how they react to getting a CGM, like right after diagnosis. And I'm curious if you came across or anything related to using CGM more as an educational tool than as a management tool. Like, is there anything on how patients conceive of their diabetes or conceive of the self-management strategies based not along insulin, more along diet or other exercise interventions, things like that?
Yeah, that's a really interesting point. I don't think I can think of a specific like case where I saw a veteran get a CGM, and then they felt like they learned so much more about their diabetes. I think, unfortunately, it's been that overwhelmed picture that I've kind of painted. Again, like, I hope I'm doing it justice, and I'm not trying to, like, sway anybody on any types of thoughts, but I do think that I've seen more of that frustration more than like, oh, I saw that I ate that ice cream and my blood sugar skyrocketed and I think I'm gonna have an apple, or not an apple, but something different. So I think that that's probably more of what I've seen.
Yeah, thanks for the great talk. I was curious, it's evident that the trends in the data are highly beneficial, and that's a major advantage of the continuous glucose monitor. To what extent is that benefit informed by lifestyle diaries? And as a practicing clinician, how often are you advising the patient to couple the continuous glucose monitor with a lifestyle diary, like a diet diary and a physical activity diary, to best inform how they might be able to improve their trends?
Yeah, so again, something that I like to incorporate when I'm giving education on the Freestyle Libre app, patients are able to enter in what they have for a certain meal at a certain time of day, as well as the units of insulin that they're giving with that meal. So I think that's an important piece of information to include at those like initial visits when we're talking about initiating a CGM, that it's always important to continue to log all that information in the app. Again, can make it easier for some who might be tech savvy, but can also cause frustration for others who, can't navigate, again, the interfaces as well as maybe other people. Yeah, thank you for the question. Oh. I don't think it's working, but.
So I just wanted to let folks know that if you wish to experiment with yourself, there is an opportunity to buy a CGM and use it. And all the stuff Zach's talking about, you can enter what you had for your meal, and it's pretty sophisticated. I mean, the Dexcom 7 will just, if you populate, what kind of shake, it'll say, the brand name, and you just, excuse me, click that in, and it'll say, oh, predict high rise with this meal and it shows you your carbs and your protein and all the components of that particular meal. So it's pretty cool. And if you just want to experiment with it, it's not totally affordable, but it's a little bit affordable. Let me know and I can give you the thing. I just did it as an experiment and it was really fun. For 3 months, and you learn a lot. And I think it helps you advise people on, yeah, that's a lot to enter all those meals and what your activity was. And then it will come back with a message saying, high rise predicted. Here's what you can do. You can do squats, you can do plank, you can do, and it tells you all these things. You're like, And every time you eat, you sort of hate to eat because then you feel like you got to go do something, which is probably good, but also not totally practical. But anyway, it's I think a cool experiment to do, and it probably helps us do a better job of advising our patients.
Did you feel any distress when you saw the numbers?
Of course. I think I told Hillary, and one of the surprises was a Dasbog chai.
Mhm.
They
Oh,
put
gosh.
syrup in it. And so, you don't think about the syrup.
Mhm.
And syrup, of course, is one of the things that really will, and I think that was the worst of all the things, was the Dasbog chai, sadly. But anyway, so if you wish to do it, let me know.
Thank you. Anybody else?
From Dr. Horney, I'm curious if you got a sense for our HBPC patients, how many are looking at their own data versus only the managing provider looking at the data to make medication adjustments? So like patient engagement or just provider?
Yeah. I think I can kind of speak to home-based primary care, and then also my experience in PACT, or the patient-aligned care team, like VA's version of primary care. So in home-based primary care, I don't think a lot of the patients were looking at their own data from what I could tell from a chart review perspective. A lot of them had caregivers that were assisting with the monitor. However, in contrast to the primary care patients that I was able to manage that had CGMs, it did seem that some of those patients, again, the very tech savvy, let me check my phone and see what my blood glucose reading is, people, they were always looking at it, as I'm sure I would be. But yeah.
Thank you. Great discussion. Thanks to those of you on Zoom. We'll see you. Join Joyous Jerry things over the summer. Check out the newsletter, and then join us back in September.
Thanks, guys. Am I supposed to save this recording?